Well, good morning, everyone, and thank you for the opportunity to talk. I forgot to raise my hand. I'm Don Arnold. I'm a pediatrician and a pediatric emergency medicine physician and have been caring for children with asthma for about 35 years. I have a few slides, and as you might gather from looking at those slides, they have to do with infectious diseases, but I'm going to try to make a connection here. And I was really interested in Ken Colburn's adage that if you're not at the table, you're on the menu. I shudder to think that that might apply to children as stakeholders in all of this, but actually it does. Children are a vulnerable population. They have higher exposure to environmental toxins than we do as adults, particularly by breathing in air pollution and toxins. As you sit here this morning, your respiratory rate is about 8 to 12. The average respiratory rate for a child is 20 to 24. Children have a much higher minute ventilation than we do. The surface area of a child's lung is about 75 square meters. That's about the size of a racquetball court. The size of the intestine is about 250 meters, about 2 tennis courts. But the lung is refreshed 20 to 24 times a minute and exposed to what's in the outside world. Asthma is a complex environmental and genetic disease. It is a lifelong disease. Once a child develops asthma, they will never get rid of it. The economic burden is substantial. The direct and indirect cost of asthma in the United States are $56 billion a year, and those figures are about 5 or 6 years old, so it's probably greater than that. And in our $3 trillion healthcare budget, $56 billion is worth noting. We currently have no primary prevention for asthma. The research center that I work with here at Vanderbilt is pursuing a primary prevention, but having to do more with viral infections and infectious diseases. But along the line of primary prevention, I brought a few slides. And if we look at this timeline, is there a mouse? Are you able to see the mouse? Yes. So in 1796, Edward Jenner developed the first vaccine. It was directed against smallpox. He did this over 100 years before germ theory came into being and before the cause of smallpox was even known. He developed that vaccine because smallpox in people resembled cowpox in cows, and developed the vaccine from the cowpox virus without knowing or having any idea what the mechanism of the vaccine would be. In 1928, Alexander Fleming developed penicillin. Now, it's interesting that primary prevention of disease preceded the development of our first secondary prevention, which is penicillin. And in public health, we talk of prevention in 3 ways. Tertiary prevention is an effort to mitigate the long-term impact of a disease that has lasting effects or an injury. So if a person is injured in an automobile crash, we may mitigate the long-term effects of that through prostheses and other means. Secondary prevention is to detect and treat diseases early to mitigate and slow disease progression. So this would be the kind of effort we make with antibiotics to identify a child with meningitis early in the course of meningitis and begin antibiotics to mitigate the effect of that infection. But the best prevention of all is primary prevention, to prevent meningitis from developing in the first place. And I want to use a couple slides that go through the timeline of developing the Hib vaccine. The bacterium is called Haemophilus influenza type B. The first vaccine became available on May 5th, 1985, Cinco de Mayo. I remember that day. I don't remember any other days in my career in pediatrics, but I remember that day because that vaccine changed pediatric practice forever. This is a graphic from a study at one children's hospital, Seattle Children's Hospital, with the black bars representing meningitis or invasive infections due to Hib, or Haemophilus influenza type B. The vaccine became available right about here, and we can see Hib invasive disease dropping and almost becoming non-existent. In the 1980s, I cared for a child with Hib disease, either meningitis or bone and joint infections or other serious damaging infections, about once a week. Now, the last time I had an invasive Hib infection was 15 years ago. That's the success of primary intervention, primary prevention. This is from the CDC, and this is the incidence of Hib disease before the vaccine amongst all age groups, and you can see this primarily affects children, and about half of which is meningitis. And this is also from the CDC. This is the incidence of invasive Hib disease pretty much after the introduction of the vaccine. Way up here, and now, as I just said, consistent with my experience, it's almost non-existent. I think Sarah spoke clearly about the effect of air pollution on asthma, and I don't need to go into that. But we have good data that both the development or inception of asthma in children and the incidence of acute exacerbations, or what people call asthma attacks, is significantly impacted by particularly particulate matter, inhaled particulate matter that she discussed. We know that in Southern California, over a 13-year period, when, as a result of air pollution mitigation efforts, nitric oxide and PM 2.5 came down, children's lung function and asthma symptoms also came down. There was a direct relationship. We also know that across the globe, when PM 2.5 increases, both the development or inception of asthma and the number of asthma attacks go up. And we've seen that particularly in Southeast Asia, in Taiwan and mainland China. The global prevalence of asthma is around 10%. In Taiwan, it has exceeded that in concert with increasing levels of air pollution. So I hope that those of you who are thought leaders and decision makers, as this process moves forward, and I know almost nothing about the Clean Power Plan, but I did read the article in Nature Climate Change and was convinced. I hope that you'll consider the effects of air pollution in particular on some of our most vulnerable populations, in particular children, who really generally don't have a voice at the table. So, thank you.